Hello and welcome to another edition of our Owner Frequently Asked Questions podcasts. My name's Ian Battersby. I'm Head of Internal Medicine at Davies Veterinary Specialists. And today we're going to talk about inflammatory bowel disease, also known as IBD. And I'm joined by one of my fellow medicine clinicians, Polly Froud, who's one of our senior medicine clinicians. She's been at the practice for a little while now. Hello, Polly.
Hello.
Hello. So, let's kick off straight away. So we're going to talk about IBD, and I think probably something that we've both come across is that when we first start talking to an owner about this condition is that a lot of owners have heard of IBS, so irritable bowel syndrome, and IBS is, but we're talking about IBD, which is inflammatory bowel disease, which is, they sound similar, there's just one letter difference in the acronym. But I thought it'd be useful for us to just define the difference in those conditions first.
Yeah, it's an important distinction because IBS is much more common in people than in pets. And IBS is a problem with the sort of bowel motility, so it's hypermotile. But if you actually looked at the bowel on a microscopic scale, you wouldn't see inflammation. Whereas inflammatory bowel disease does inherently involve inflammation of the bowel, and that's much more common in pets than IBS. We rarely see IBS in pets, maybe in some sort of high-performance dogs. But yeah, by definition, IBD, inflammation within the bowel, and that can be anywhere from stomach through small intestine to large intestine.
Okay, so we've got this inflammation in the bowel. I mean, we should say that your bowel normally inflames when you've got an infection, for example, but this is inappropriate inflammation. This is inflammation and the lining when we don't want it to be present. So what causes that inflammation if there's not an infection there?
So you're right, we have to sort of rule out other causes of the inflammation in the first place to kind of diagnose the IBD. And really it's kind of the gut's own immune system going wrong. So normally the gut has quite a difficult role of responding appropriately to potentially harmful organisms or tolerating, kind of ignoring harmless substances like food antigens or kind of friendly bacteria. And in IBD, we kind of get a shift in this balance towards the gut overreacting to non-harmful substances. So things like food proteins and friendly bacteria can be the driving force for the inflammation. But we also know there's a genetic component to the disease because certain breeds are definitely more susceptible. Saying that, it's not a sign of bad breeding, and we can't kind of try and breed it out of a line. And also we can see it in any breed.
No, and IBD is something that I learned a lot about during my residency. I always thought it was just amazing that, the bowel, the more you think about it, the more complex a role the bowel has. It's got this system where it's got to work out that's a friendly bacteria and that's a non-friendly bacteria, and understandably that's a really complex system. And with any complex system, there's going to be potential chinks, and hence, this inflammatory bowel condition. So how does the inflammation being present in the bowel, how does that cause what clinical signs does that result in, and how do they manifest?
So the clinical signs can vary depending on which area of the gut's affected, but also in severity. So we can see very mild clinical signs at one end of the spectrum. Sometimes this is just pain after eating, so sort of colicky signs, or sort of subtle drop in energy, lethargy. And then we can get the sort of classic gastrointestinal signs, which are vomiting and diarrhea, sometimes a loss of appetite. Occasionally the appetite's increased, paradoxically, because they're not able to absorb the food that they're eating, but I'd say typically poor appetite is more common. And then at the more severe end of the spectrum, we can see weight loss. Occasionally we can get a form of the disease where the protein levels drop, and that can have consequences like a pot belly because there's fluid accumulation in the belly. And that's the sort of the most severe manifestation of IBD, and we call that protein losing enteropathy. And the signs can wax and wane, or they can be more persistent.
So it's quite it's one heading of IBD, but it's quite a broad kind of umbrella, really. Of different severities. You've got very mildly affected cases that some owners may only notice a little bit of of inappetence occasionally. To those patients, like particularly with the protein loss, they need hospitalisation, a lot of aggressive treatment. So we often, I guess, we talk about it being lots of, there's lots of different subtypes, but we just keep it under the umbrella of
Absolutely, yeah, it's quite a wide spectrum. And sometimes we'll see it alongside other symptoms, especially in cats. We can get inflammation of the liver or the pancreas or both alongside IBD. So that might affect the clinical signs. If the liver's involved, we might see jaundice, yellow mucous membranes. And in young dogs, if there's a strong sort of food allergy triggering the IBD, we might also see that in the skin. So they might have a history of allergic skin disease as well, which especially manifests as recurrent ear infections. So a young dog with recurrent ear infections and gastrointestinal signs would put a sort of food allergy component on the radar.
Okay, cool. And you've already, I should have said at the start, when we're talking about IBD, we're talking in general terms. This is both applicable for cats and dogs.
Yes, yeah.
Just one species. So if we have a patient in our clinic and it's referred to us, and let's say it's got classic vomiting and diarrhea rather than the more unusual manifestations, and you've got a suspicion of IBD, what kind of diagnostic tests do you perform to reach that diagnosis?
Well, we often start with blood tests, and that's more to rule out other possible causes for that vomiting and diarrhea rather than there being a sort of perfect blood test that confirms it in one easy go. But we also use it to look for some of the consequences of IBD, especially the protein levels. But we're looking at sort of other organ function, liver, kidneys, pancreas. And we might want to rule out certain hormonal diseases that can also cause waxing and waning gastrointestinal signs, especially a disease called Addison's. We may also want to check vitamin levels on a blood test because the B vitamins can be low with IBD, and that can help confirm our suspicion that this is a primary gut problem. But it's also really important when it comes to treatment because we need to supplement those vitamins to help the patient respond. So yeah, we'd start with blood tests. We may, if there's a lot of diarrhea, we might want to submit a fecal sample to see if there's an infectious component. That might not be all that's going on, but it could be a contributing factor. And then we've done, sorry.
So we've got our, you didn't know. So we've got our general screening. So you've said, I mean, in summary, there's causes of vomiting and diarrhea that primarily affect the bowel, and then there's the non-bowel ones like the hormone conditions. So the initial screening is assessing the non-bowel. So then we focus on the bowel. What are the tests that we do in that situation?
So we usually want to image the bowel, and our first choice is usually ultrasound, which we can perform just under sedation. And we're looking, especially at the bowel, looking for any changes there, like thickening of the bowel walls, any loss of the normal layering. So we can normally see on ultrasound the different layers within the bowel itself. And sometimes they are less clearly demarcated with severe disease. We might also see enlargement of local lymph nodes, draining glands. And obviously we're still interested in the other organs, so we can still assess those during the scan, like the pancreas again. If we see anything that we might be able to sample, we sometimes also take a needle biopsy there and then, which is just a matter of passing a small needle in and sucking out a few cells, because sometimes that gives us a diagnosis without the need for more further sort of invasive biopsies.
And I guess the ultrasound as well, sometimes we might have a suspicion of IBD, but we might find something causing obstruction in the bowel.
Exactly, yeah. So we're looking for foreign bodies, looking to rule those out, things like intussusception.
So after then, I suppose there's two options. If you have a strong suspicion of IBD, you can put in treatment, but we'll talk about treatment in a moment. The other option is to then go on and confirm, typically that might be a diet, and we'll cover on that in a moment. But if you in some cases, depending on the severity, we'll then move straight to the full diagnostic workup. What does that involve?
So if we want a definitive diagnosis of IBD, ultimately we need some sort of gut biopsy. And you're right, in some cases we don't need to go that far. We can institute a treatment trial first, but in the more severe cases, we'd want to get that biopsy sooner rather than later. And we have two main ways of achieving biopsies. We can either perform an endoscopy and then get a visual inspection of kind of the lining and take some pinch biopsies, and these are sort of superficial biopsies. Or we can take surgical biopsies where we open the dog's abdomen and take what's called a full thickness biopsy, and that's where we're actually taking a sort of section right through the gut wall, so we're getting all the layers rather than just the superficial layer. Now, often the ultrasound helps guide us here, because if we're seeing generalized changes throughout the gut, endoscopy would probably be our first choice. Whereas if there's one area in particular that's affected and it might be out of reach with endoscopy, or we don't think we're going to get to it with endoscopy, then that might push us more towards surgery. But it's always a sort of informed group decision, and there are some factors that might, again, sway us away from surgery because of increased risk of complications. For example, if we are dealing with one of the more severe forms of protein-losing enteropathy, dogs with lower protein levels have a higher risk of wound breakdown after surgical biopsies. So the surgery is a bit more involved. They're in the hospital for longer, whereas with endoscopic biopsies, they can usually go home the same day.
Yeah. And I guess when we're talking about wound breakdown, we're talking abdominal wound, but we're also talking the risk of intestinal leakage. And that
and that's the big concern.
Okay. And then when you talk about the endoscopy, so for those of you who don't know, the term endoscopy is using a camera to go into a body cavity. There's different, I suppose there's upper and lower endoscopy that you perform. What kind of cases do you do both ends? I'm trying to think of a delicate way of putting it. What's the slight differences in how you approach that?
It's guided partly by the clinical signs. So the clinical signs give us a clue as to which part of the gut's affected. So typically, if it's the sort of upper end, the stomach and the small intestine, we'll see vomiting and what we call small intestinal diarrhea. And that's when it's high volume, watery, but there's not really a lot of straining or mucus or fresh red blood. And weight loss can be a feature of a sort of upper GI disease as well. Whereas if we're dealing mainly with inflammation in the colon, colitis, the classic signs are sort of defecating more frequently, straining to go, not necessarily passing large volumes, but a bit of blood, a bit of mucus is quite common as well. Sometimes we need to do both because all the symptoms are present. And then sometimes the blood tests guide us a little bit, because if those vitamin levels are low, that points us in the right direction as to where the problem is likely to be in the bowel, because different segments of the bowel are responsible for absorbing different vitamins. So that can also be a deciding factor. And we can, with the sort of lower endoscopy, we can access the most distant part of the small intestine as well a lot of the time. So that gives us another route there.
And what about the preparation for a lower endoscopy, because that's a little bit more involved, I guess?
Yes, I mean, for any endoscopy, ideally we want a 24-hour fast to get really good visualization of the mucosa. We don't want to miss any small lesions. So we'll classically ask the patient to be hospitalized the night before the procedure. With a colonoscopy, it's even more important to fast them, but ideally we also want to kind of cleanse the bowel in some way. So we do offer them a sort of bowel cleansing fluid, which they don't always drink voluntarily, understandably, and we perform enemas either before or under the anaesthetic, immediately before the endoscopy.
Because I mean, but particularly with the colonoscopy, as you're saying, prep's key, because if you put the camera at the end of the scope's literally the size of a pinhead. So if you've got lots of feces in there, it's easy to miss things. So if we talk about treatment now, so we've made our diagnosis. Let's say it's a dog, for a Labrador, for argument's sake. We've already hinted at some of the things that you put in place, largely because of our suspicions of why this condition occurs, and that we can group it under dietary management, treatment focused on the manipulation of the friendly bacteria, that might be an intolerance to, and then there's drug therapy to control the inflammation. Now, some of those cases, I guess, would need, the more severely affected cases need all of those meds put into place, ASAP. But if we maybe talk about a more stable case, because I guess we try and phase in the different aspects of treatment, and maybe just start firstly with diet.
Yeah, so diet's often the starting point, and it's hard to kind of overemphasize how important diet is in managing this condition. And the aim of the diet, it has two roles really. First of all, it's easy to digest, so it's gentle on the guts, but also it's what we call hypoallergenic, or it won't stimulate that inappropriate immune response. When dogs have become sort of sensitive to a food, it's not that they've been on the wrong food, they're just sensitized to something their body has seen a lot of. So by choosing an exclusion diet, we're trying to feed them something that the body hasn't seen before and shouldn't overreact to. And we have a couple of options. We can either feed them what's called a novel single protein diet. So literally picking a protein flavour that's unusual, not in a lot of standard commercial dog food. So we try and avoid things like chicken, beef, pork, and go for slightly more exotic flavours like venison, salmon, duck. And there are prescription diets that are fully balanced and just based on those single protein sources available. Typically proteins are more of a culprit than carbohydrate, but we do avoid gluten as well, so they're gluten free. So that's one option. And then some very committed owners actually home make a diet based on that one novel protein source. That's another option. Although if it's long term, we do have to be careful that it's fully balanced. And then the other type of exclusion diet is the hydrolyzed diet. And there the protein has been broken down so that it's too small to stimulate the immune system. And that's quite a good option if you've got a pet and you're not sure what they've had before. Say it's a rescue dog, so you have no idea what would be novel for it. The hydrolyzed diet's an easy option to cover that base. But there isn't one diet that suits all, and it's very much a process of trial and error. And we can find that one patient will respond very poorly to a hydrolyzed diet and then brilliantly to a novel protein diet, or vice versa. With any diet trial, we have to give it time to work as well. So typically we give them 2 to 4 weeks, and we often see a response after 2 weeks. But if they don't respond to the first attempt and they're stable, it's definitely worth trying another diet, just in case we're luckier with that second attempt.
Yeah, and I guess when we talk about the home cooked diet, as you say, some owners elect for the prescription diets, essentially because of ease. It's quite a big commitment to make a diet specifically, but there are a few vets in the country who are qualified nutritionists who can balance that diet for long-term use, that can be referred to. I thought I was going to have a good question, and I can't remember what it was. What was it?
We often get asked about treats. So yeah, treats to a dog, a treat is just a bit of food at a time other than mealtime. And owners often get very distressed on their behalf that they're not going to be able to continue giving them treats. But actually, you can just use the kibble from the exclusion diet and give it at the time that you would give a treat. Or if you really want to indulge them and you're on one of these novel protein diets, you can select that protein source as a fresh meat. So say they're on a venison-based prescription diet, you can get them some fresh venison and chop it up and put it in the freezer and get one of those out intermittently. And there are sort of freeze-dried single protein source treats out there as well. But it's really crucial that they are just on this protein source alone or just on the hydrolyzed diet, because the smallest bit of scavenging can upset them and undo all your good work. And I sometimes use the analogy of a peanut allergy, just thinking how small a trace of peanuts are needed to cause a reaction. And it's a little bit like that with maintaining the exclusion diet to optimize treatment of IBD.
And I guess one thing as well, I don't know if you've done it, I've done it in the past as well, is that sometimes in tricky cases you use a hydrolyzed diet to stabilize them, and those diets are quite expensive compared to normal diets. And if you show that it's dietary responsive, then you have an opportunity to look for an alternative diet that may suit that bowel.
Yes.
And when we talk about the importance of keeping religiously to this diet, and affecting treats and things like that, what about scavenging or hunting?
Yeah, they can be a massive problem, and we do sometimes recommend muzzling dogs, especially on walks, if that's when they're most likely to get the opportunity to scavenge. And it does feel a bit like being cruel to be kind, but actually they get used to it very quickly, and it is the best way of stopping it happening. It's a little bit harder with cats that hunt, so obviously the extreme way to prevent it would be keeping the cat indoors, but understandably a lot of people feel that wouldn't be compatible with good quality of life. So you can try other things like collars with bells on to hopefully reduce their hunting efficiency. Or sometimes with cats we just have to reach a happy compromise and accept that every now and again they will hunt, catch something, and that might upset the apple cart, and then maybe we use other measures like drugs to try and get symptoms under control again and let the diet take over once things are more settled.
With respect to diet, I can certainly think of a few cases that have been referred to me and they've been on lots of drugs but the dog's been going out on walk or going in the garden and scavenging lots of material. And I suppose that's a good point to highlight. You know, if you had a nut allergy, use that as another. It's not quite the same, but it's a similar example. No amount of drugs are going to stop you reacting if you keep eating peanuts. You know, it's the same with the scavenging.
Yeah.
So if we talked a bit about diet there, and if we have our patient that's failed, you know, done the diet trial well and it's failed that diet trial, the next phase is looking at manipulating the bacteria, or what's called the microbiome. And what kind of treatment options are there for that?
So traditionally, we use antibiotics to try and modulate the microbiome, but increasingly there's suspicion that maybe that doesn't achieve a normal bacterial environment again. And also we have the disadvantage of it potentially promoting shedding of antibiotic-resistant bugs in the environment. So there's increasing interest in probiotics and how they can be used instead to modulate the bacteria back to a more normal population. They're very popular in people, as you probably know. They've been very effective for treating Clostridium difficile. I think the difficulty in pets is we don't know for sure which work best yet, but it is an area of sort of active research, so hopefully that information will come with time. And it's important to establish a normal microbiome, because then you don't get higher numbers of the wrong bugs, that they're not necessarily going to cause disease, but they're more likely to stimulate the immune system in the wrong way. But also a healthy microbiome has lots of other advantages. It kind of aids digestion and just helps promote a healthy immune system.
So yeah, that's phase 2. So then we move to phase 3, which is, you know, using drugs to control this inflammation, and the inflammation's causing maldigestion, and that's why you're getting all the diarrhea and the weight loss. So what's the typical first line drugs that we use?
We'll often use steroids first, and that's usually oral, unless the patient's sort of not able to keep medication down, or worried that they aren't going to absorb it because their sort of gastrointestinal signs are so severe. So occasionally in a sick hospitalised patient, we'll start off with injectable steroids, but then switch to oral. And prednisolone is the most commonly used drug. Sometimes we'll use a drug called budesonide, which is more locally acting. In people, budesonide has significantly fewer side effects on the rest of the body compared to prednisolone, but in animals we think the benefit is probably less marked. So there will be occasional patients where we think budesonide might be worth a try, but prednisolone would usually be our go-to.
And I guess we should say, I mean, both as medicine clinicians, we both use a lot of steroids because we see a lot of steroid responsive cases, but there's always a payoff, you know, because at the dosages we need to use, sometimes there's side effects. What kind of side effects can these steroid drugs have?
Yeah, so we are using high doses, especially at the beginning, and the most common side effects would be increased thirst and urination, increased appetite, and sometimes lethargy, weakness, panting. And these might just be not very detrimental to the patient and tolerable, especially if only for a short period of time. However, sometimes you know, they really are debilitating, and the patient has completely lost interest in life, or is getting owners up multiple times a night because it needs to go out to the toilet. So the side effects can be a limiting factor, and we always counsel owners to not suffer in silence with them. If at all concerned, to let us know, because there is the option of potentially reducing the dose sooner, introducing other drugs to be able to use a lower dose. It's important not to stop steroids suddenly, because that can cause its own problems. But we can, you know, modify the treatment to reduce the side effects. And there are other potential side effects with long-term use. We can occasionally see development of diabetes, even gastrointestinal ulceration, usually when there's a risk factor there already.
Yeah. And I guess particularly because we're talking about dogs and cats, long-term steroid use in a cat, that's where you've got to worry more about the increased risk of diabetes.
Yes, cats are especially susceptible to that. We can also see muscle wastage, so that's quite common, especially in larger breed dogs. They tend to be even more susceptible. So we can start to see a sort of a bony head, bony shoulders, and weakness can go along with that as well.
Which is challenging when you've got a patient that's got weight loss, because it's
yes,
condition.
yeah.
It's always a difficult call.
Yeah.
And you know, not all cases respond to steroids, or some cases get lots of side effects from the steroids. And we do have second line drugs, and I guess there's a little bit of difference between dogs and cats here. What are those options?
Yeah, there are several sort of second-line drugs that have been tried. All have their own sort of subset of side effects, and some of them need closer monitoring in terms of blood work. So some of them can cause bone marrow suppression. And any of the immunosuppressive drugs have the potential to increase the risk of a sort of secondary infection. So by nature, they're suppressing the immune system, so we can occasionally see opportunistic infections creep in. And if we have a patient that needs multiple immunosuppressive drugs to control its disease, obviously that risk increases because we're hitting the immune system harder.
Yeah. Okay. And so we've got the primary drugs that we use, the primary treatment approach. What about worming and vitamin supplements in these cases? Do they have a role?
Yeah, definitely have a role. So if we've sent off a fecal sample and it's come back showing parasites or something like Giardia, then we'd want to treat that. And we always tend to make sure worming is up to date when managing these cases anyway, because it's possible to get what we call false negative results with a fecal sample. And even if a sort of infection isn't the main cause of the disease, it will be a flare factor. And then vitamin supplementation, absolutely necessary. We can see cases that will not respond to any of the other treatments until you restore their normal vitamin levels. So vitamin supplementation can be given orally. There are products that combine that with sort of probiotics, so it's giving everything in one. So yeah, definitely worth addressing and kind of checking that levels have corrected with treatment of the underlying disease.
So is this, I mean, if we get a patient that responds, do they have to stay on treatment for life, or is this like a short-term period?
So our ideal patient we'd want to wean off after a period of about 2 to 3 months. So there's just a gradual reduction in dose over that time period with close observation for any signs of relapse. But in some cases, we find that we get to a certain dose level and then signs come back, or we try stopping treatment and they have a relapse straight away. So it's not always possible to wean them off the medication, but we would always try. That would be our kind of target. So yeah, the treatment can vary in duration. It might be that we can wean them off after 3 months. It might be that they're on a low dose persistently, or that they just need a repeat course as and when they have a flare-up.
So I guess in summary, if you've got a sensitive, I mean, it's not sensitive. I suppose IBD is like a bowel sensitivity. Once you've got a sensitive bowel, you're always pretty much going to have a sensitive bowel, and it's just working out the regime that works for your pet, which can take a bit of trial and error, that doesn't have a big impact on their quality of life. And I guess when we're talking about side effects, I guess, would you agree?
Yes, absolutely. So it is a juggling act. There are some sort of younger dogs that we think probably do sort of self-cure. So if they're diet responsive, we find that after a long period on that diet, sort of at least a few months, they can actually tolerate any food again, but they're the minority. So that, yeah, from the majority of patients, this is a lifelong condition, and we're looking at management rather than cure. And our sort of number one aim is quality of life, kind of taking into account side effects from drugs and everything else. But the diet will be the sort of the long-term therapy throughout.
Yeah. And I suppose that's just reminded me of another frequent question that we get. So if we have a dog that has had diarrhea for 3 months, you put it on a diet trial and it responds, is it okay to move away from that diet? Or how should I phase in new food?
It's sort of always kind of your personal concept of risk. So there is a risk with reintroducing any other food. So we'd want to give a treatment trial of sort of a minimum of 4 weeks to see if they respond. And if they respond brilliantly, I would encourage feeding that diet for at least another couple of months, so that we fed it for at least 12 weeks in total. At that stage, if it's a young dog and you are willing to take the risk, especially if the signs were mild, so hopefully it's not going to be a massive deal if there is a relapse, you could then try gradually reintroducing food that the dog had before, if you don't want to stay on the prescription diet for life, and then just look out for recurrence. And if signs recur, then it's more likely that patient needs an exclusion diet longer term.
And finally, just with respect to monitoring, we've talked about these patients being on diets and drugs and things like that. Are there any blood tests or any clinical scores that owners need to do with their vet's assistance?
So blood tests, not so much. We might use them to monitor some of the drugs, but they won't necessarily tell us so much about whether the disease is under control. A lot of it is based on clinical signs and clinical response, and that's quite nice in a way, because it means we can do a lot of remote advising. So the owners often give us an update after 2 to 4 weeks, and then we can advise on the next step just based on that update, or also asking the primary vet to examine the patient and see if there's weight gain, assess for side effects, especially some of this muscle wastage. And there are clinical scoring systems in place that take into account lots of features, so the clinical signs like the vomiting and the diarrhea, but also the body scores and things.
Yeah, so I guess there's a number of, I mean, that's the thing, it's not, there's only the really severe cases with the protein levels you need to keep an eye with the blood tests, but most of the clinical observations, so weighing the dog, and then as you say, there's the poo chart scoring system, which we all smirk about when when we talk about grading poo, but actually it helps kind of monitor changes in fecal quality, a little bit less subjectively. Which is useful. Well, thank you so much for that great summary, Polly. I hope that everybody at home who's listening has found that useful, particularly if your pet does have IBD. There are other owner frequently asked question podcasts on the DVS website, some relating to different conditions. If you have other ideas of conditions that you'd like us to discuss, then please feel free to let us know, and we can hopefully sort something out. All the best. Bye-bye.
Thank you. Bye.